Dr. Koh, thank you so much for coming on. I know you're remarkably busy at the moment. It's very kind of you. Whereabouts are you, Dr. Koh, please?
I'm in Manila. I stay in the National Capital Region where we have the most cases of COVID-19 in the Philippines.
So is Manila a busy city? Is it quite a populated city?
Yes, it is. It's a very densely populated area. We have about the size of 660 square kilometers, but we have at least 13 to 15 million people.
Wow.
Within the Metro Manila area.
Right. Wow. And what's your job, Dr. Koh?
Sorry?
Well, what do you do? What's your occupation?
Well, I wear many hats. I'm connected with 3 hospitals. I'm basically a pediatrician and an infectious disease specialist, a subspecialist, and another subspecialty is clinical and molecular pharmacology. So I used to teach clinical and molecular pharmacology at the university before I decided to retire. So currently, what I do is I still practice at 3 different hospitals in the National Capital Region. Asian Hospital and Medical Center, where I am also the chair of the Research and Ethics Committee. At the University of Santo Tomas Hospital in Manila, I am the chief of pediatric infectious disease. And at Cardinal Santos Medical Center in San Juan, which is still part of the National Capital Region, I am the chair of the Pharmacy and Therapeutics Committee.
Interesting.
Yes.
Indeed. You are indeed a busy man.
Yes, 3 different hospitals and 3 administrative positions.
Wow. Yeah, I would be no good at the administration, that's for sure. So, I mean, just before we talk about COVID-19, obviously, what is the burden of infectious disease like in the Philippines? And particularly, is it different for adults and for children? So if we start off with the burden of infectious disease in children, first of all, in the Philippines, what's the sort of, what problems do people suffer from in the Philippines in terms of infectious diseases in childhood?
Well, the Philippines is still a developing country. It's a third world nation. And as in many third world nations, infectious disease will be the #1 cause of morbidity and mortality. So it's quite similar to most of our Southeast Asian nations, except for Singapore, but we probably are more similar to Indonesia, Malaysia, and Thailand, where the vaccine preventable diseases are still the most predominant infections we have in the country. In comparison to adults, on the other hand, most of our adult patients have more non-communicable diseases than infectious diseases. So, in spite of the fact that we are a developing country, we've been able to manage a lot of infectious diseases very well because of immunization. Vaccines and vaccine preventable diseases are actually held at bay for the pediatric age group. Because the government actually has its own expanded program on immunization, which is very good. The government puts a lot of money also into our we call it EPI, or Expanded Program on Immunization.
Right. So without that, then the conditions in children will be a lot worse. Vaccination is what maintains the health in childhood primarily.
Yes, you are right, John.
Yeah, thanks. And is the vaccination program basically carried out throughout the country, or is there some areas where the vaccination is quite good and other areas where less children get vaccinated, in rural areas, for example?
In general, most of the vaccination is from north to south, which means that it covers almost all the 7,640 islands within the archipelago.
How many?
7,641 islands in the archipelago.
Wow, I've learned something. Thank you. Yeah.
But see, There will be some areas that will be difficult to reach, okay? Especially those wherein there is poor access to health. But we do try. We do try. We have medical missions and the government is involved in programs. Also, it has a health center in almost every barangay. We call them barangay, especially the smaller towns and municipalities. There are areas that are quite difficult to reach, but they are far and few.
Mm.
The majority of our of the kids, we are a predominantly young country. The average age in the Philippines is about 27 years old, and almost 52% of the population are actually pediatrics. So we are 110 million. We are a predominantly young. Well, if you look at the age group for our country, we're predominantly young.
Mm. Right, yeah. And just before we go on, what specific diseases would be a problem without a vaccination? What are these diseases called?
Well, we have dengue as a problem, but we had the vaccine. Unfortunately, I'm sure if you're aware of the story behind dengue in the Philippines, and if you're up to date with it, the vaccine is non-existent anymore because of political reasons.
Ah, right, okay.
Um,
The dengue vaccine, yeah.
yes,
Yeah.
yes, we were actually the first country to have it available in the world, but unfortunately, because of certain issues and political problems, I think we don't. Well, we don't have it anymore because I think of I think it's more political rather than a vaccine problem in itself.
So that sounds fixable, yeah, yeah. Okay. So it's presumably that it's diphtheria, polio, tetanus, mumps, things like that, the routine, the common childhood diseases that would be a problem without the vaccination.
Yes, it would be a problem. We've had some outbreaks of polio before we came into the COVID-19 problem. We were having some problems with polio, but they were in specific communities and they were far and few,
Right.
which was really not a very big issue for us. But once we spotted them, we started, well, the Philippine government started mass immunization and rebooted the oral poliovirus program. There was, see, sometimes when there are disasters that occur, because we are a calamity prone area, some of the kids miss their immunizations. So, we, right before all of these things happened, um, I was referring to you regarding dengue. Remember? A year or two before the outbreak of polio, the outbreak of measles that we had, the immunization rates actually in the country were very good, especially for public immunization. Unfortunately, with the politicization,
Yes.
well, of dengue, people were afraid to get their people became afraid of having their kids immunized. So there was a slump in vaccine coverage, and a slump in vaccine coverage removes the gains you have
Mm.
for vaccine preventable diseases. So
Mm.
for a
And put the
while
yes,
after,
can't it?
yes, so after we had problems with dengue, um, and the vaccine got pulled out of the market, we had several disease outbreaks, including measles, so including dengue, including polio. So we had these three come together um, almost continuously, and we were, well, because like I said, we're a calamity.
Mm.
The country is in an area wherein most of the calamities will overwhelm us. We had a volcano erupting, We had storms coming in our ways, and it made it the perfect storm.
Indeed, indeed, literally and metaphorically. Yeah, absolutely.
Yeah.
Yeah, yeah. So COVID-19 is like another problem on top of the infectious disease burden you already have.
Yes.
Yeah, yeah. So how prevalent is COVID-19 at the moment in Manila, for example? Are you seeing a lot of cases?
Well, in the Philippines, since the outbreak, and we recorded the outbreak actually officially in January, we had three cases. The first three cases we had were foreign. Three Chinese from Wuhan came into the Philippines. The three of them got sick. One died. The other two recovered, and we had a lull in between. But I don't think the lull was an actual lull, okay? Which means that for any infectious disease, and I always tell my medical students that for any infectious disease, if you see one case, there probably is another case lurking somewhere, or these are patients that may have had mild symptoms, and we just did not do enough contact tracing at that time, and we probably got side, sidelined by the fact that we had a calamity also during January, which was the eruption of the Taal volcano. So all eyes were actually on the relief program for that. And then we had polio outbreak in February. So everybody was into the polio virus, the oral polio virus program of the government, unfortunately. So that was the lull in February, and then March saw the first spike. The actual cases were coming in bulk already. And that was when the president declared a semi-permanent, we call it an ECQ, or an enhanced community quarantine, in the National Capital Region, because we had um, a handful of cases already, 30 plus cases at that time, which was something that, and then we had local transmission already, which was alarming. And that's when we started seeing the numbers go up. At present, we have at least, we broke the number already, the 30,000 number, which is very little compared to what you have in the UK. So we have
Indeed,
30,000.
indeed.
We have 30,000 cases in the whole country, and everyone is on walking on eggshells with the 30,000. We have 1,100 deaths so far. So we're averaging about now we're averaging around 3 to 5 deaths a day, which isn't really that bad.
It's a lot
And
lower than the UK. The UK was down to 15, but that was the lowest since March.
yeah.
So, so is this genuine, or does this reflect limited testing, do you think?
Well, I think it's real. I think it's genuine, in the sense that if you look at the testing data that we have, we've had 600,000 tests done so far, and these are by RT-PCR, or reverse
It's
transcriptase
the most reliable
polymerase
test.
reaction. Yes, yes. So all of these patients that we've had, the overall positivity rate is for yesterday was 6.3%. When we started this, it was very high, and we had limited testing. When we started RT-PCR testing at the beginning of the pandemic, we had around 15 to 18% positivity rate, which means we were not testing enough. Testing enough means that you need to go low, you need to have lower positivity rates. And today we fluctuate between 5 to 7% positivity rates overall. But of course, the more dense areas, the areas like the National Capital Region or Region 7, particularly Cebu City, which is hardest hit now. And we don't know if the epicenter is now shifting, because the National Capital Region is in Luzon, while Cebu which is similar to the National Capital Region, is in the Visayas. So
Separate areas, yeah.
the past few days and weeks, they've been having a spike in numbers. With the last couple of days, Cebu had more cases than the National Capital Region altogether.
Yeah, so different regions being affected to different degrees with different amounts of local transmission.
Yes, but if you look at all the other different, we have 13 regions in the country. Not everybody has the same numbers as us, because if you look at all of the other regions, they have 1 case a day, 2 cases a day, 4 cases a day. It's if you look at all the regions that have the most number of cases, it would probably be the National Capital Region because of our density.
Yeah.
Region 7, which is also another dense area. Region 8 now has had several cases, but I think they're attributing these to the repatriates that we're getting. The OFWs, or overseas foreign workers, Filipino workers that are coming home in bulk. And then Region 4A, which is Calabarzon, which is the region that is right surrounding the National Capital Region. So they're getting cases too. The average is about 40 to 60 a day. Again, it's not a lot, not that much.
It's impressively low. Why do you think it's so low compared to, say, New York or London? You've got a
That's a good
dense
question.
city, highly populated city. The disease is there.
I know.
I'm impressed. I'm pleased. I just hope it keeps up. But
Right.
what's happened? How do you explain this?
But everybody here is panicking. You see, even with our very low numbers, I think the enhanced community quarantine, even though it came a bit late in March, I keep telling the people at the Department of Health that should have been that quarantine, that enhanced community quarantine should have been placed way back when we saw the first 3 cases among the Chinese.
Yes.
And we should have shut the border, the same thing that Vietnam did. But
Then you
I
could have done a
understand.
New Zealand in that case. It could have been like New Zealand and
Yes,
yeah,
yes.
closed it off. Yeah,
Right.
yeah.
That's what you need to do. I mean, it's basic infectious disease. Like, I'm an infectious disease, I do infectious disease. And once we see in the intensive care unit, one of our patients has a growth in the blood, in the bloodstream, or bloodstream infection,
Yes,
we isolate the patient immediately,
yes,
because hospital staff cannot be transferring that particular bloodstream infection to other patients. Okay? And then we make sure that after we have isolated that patient and all of the patients have been cleared, we shut down the ICU and we clean it. So it's the same thing that we're seeing with any infectious disease like this. But of course, you need to shut the borders, but we did not do that early. We did that sometime in March when we already had a string of cases. But the enhanced community quarantine actually helped. And the other spike, well, we saw we were seeing about 150 to 250 to 300 cases on the average in March and April. In May and June, this went up to about 600 to 700. And we think that the May and June, I think the ones that you see in May and June are probably the ones that are now in the urban poor, because the urban poor community is a very large community in the National Capital Region. If you look at the whole data of all of the 13 regions in the country, those that are more provincial, those that are more or that are more rural, have actually spotty cases. They're very few. They're not as many as what we have in the National Capital Region. Why? Because, well, they're farmlands.
mm,
One house is very far away from another house. And the communities are actually uh, fewer in number compared to National Capital Region, where you have, like for example, Quezon City alone, Quezon City, which is one of 17 cities in the National Capital Region, has a population of about 2.5 million.
Yeah. Often living in very close proximity.
Yes, yes. And there are a lot of urban poor communities in the within the Metro Manila, within the Metro.
So there's obviously community transmission going on because these cases keep popping up, but obviously there's no exponential growth like there has been in other places. It's
Yeah, and what we've been seeing is that well, it's not an actual exponential growth that we're seeing. We're seeing some of the cases pop up in certain urban poor communities now. What the
yes.
local mayors actually do is they lock them down. So they're doing a local lockdown instead, and they quarantine certain, we call them barangays. So we quarantine certain barangays, but there are actually quarantine and isolation facilities within each local government unit. I just for the hell, I don't even know why they don't want to use it. Maybe it's because some of the some of the patients don't want to be quarantined in a government facility. I'm really not sure why they don't like to use it, but we have several government facilities for quarantine.
So the message I'm getting here really is it's good localized administration, quickly reacting to cases, closing down particular areas and small regions on a dynamic basis.
Yes.
And you've got population compliance with these measures.
Yeah.
So the attack on the disease is quite targeted and quite specific
Yes,
to
except
where
that
the problem is.
they're really well. They can do better. That I think my point is they can do better so that we see the numbers drop down dramatically. And when I say that they can do better, and I've been saying that because I write a blog. I have a blog actually, and I started.
We'll post a link to that, of course, if you don't mind.
I don't mind. Some of the media have actually picked up on the blog, and that's the reason why suddenly I'm being interviewed left and right for I do not know what reason at all. But
I think I've got an idea because you're very well informed.
well, what happens? What I suggested what I suggested once, sometime way back in March, was that should we get out of the enhanced community quarantine, each local government should actually prepare itself, which means that every local government should have A, its own testing centers, and B, its own isolation and quarantine facilities. And you should not make a local government you should not get the local government out of the general quarantine procedures if they don't have these two basic things. Because what's going to happen is that if you lift the quarantine and you have patients within your area getting the disease, and then you're going to make them stay and occupy another local government's facility, you are going to overwhelm the other local governments for that. So I think basically we're not there yet. The second, we're ramped up in testing facilities, which is very good because we have about, let me see, we have more than 59 testing facilities already in the whole country. We
Are the
start,
tests produced in the country?
sorry.
Are the tests produced in the Philippines or are
Oh,
they imported?
we have one which is produced in the Philippines by the University of the Philippines, but we had to stop that because there was some contamination in their testing kits.
Okay.
So, yeah.
And is there any antibody testing as well at the moment?
Yes, there is a mixture of rapid antibody testing and immunoassays at the same time, but we don't actually advocate the use of rapid antibody testing routinely. Um, it's cheaper, but the gold standard is still RT-PCR. And
Yeah.
all our patients, all our confirmed cases in the country are documented using RT-PCR.
Now, is the clinical presentation of COVID-19 in the Philippines comparable with what you've read about in other countries? That people have the fever, the dry cough, the tiredness, the myalgia.
Yes, actually, in the beginning, when we were seeing a lot of patients coming down with it, that was the primary presentation. I have had colleagues, friends who passed away from COVID-19. Um, and they start off with fever. Later on, there's dry cough. There is a sudden shortness of breath. And it is correct that when these patients get intubated, the outcome is actually grim. Most of the patients, most of my colleagues that got intubated actually passed away. Those that did not are the younger ones. So the probability of mortality is around 80% after intubation. And at that time, we were scrambling for the kind of drug to use, whether we were using hydroxychloroquine with or without azithromycin, with or without any monoclonal antibody together with it. There was no remdesivir that was available at that time. Now we are part of the Solidarity trial that's being done by the WHO globally. So I guess those are some of the reasons why we probably have better outcomes today. And B, the we know already which are the at-risk groups. So the at-risk groups actually stay at home. They don't like to come out, including my mom, and those that have comorbidities. So when people find out that they have comorbidities, they know that they should not be going to crowded places. So they try to avoid it. And these
Are
are
these people supported at home? Do they get food and provisions and things delivered to them?
Now, yes, actually, the government provides. We call it in the Philippines. We call it ayuda. That's the term that we use, and ayuda means help. So the government provides rice, canned goods, and some cash for the workers that have been displaced and for those that are sick, or for those that are confined at home, or those that are quarantined at home for a while. But like I said, it's still not the right thing to do, because the better thing to do is once you've isolated, you found out there is somebody in the community, particularly the urban poor, where the room is like 15 square meters and that's their whole house. If the your house, the room that you're in right now
Yeah,
is occupied usually by about 17 or 10 to 17 people in the urban poor
yeah.
community. So it's easy to get infected, and the transmission there will never end. You need to move out these people, test now the people that they have come in contact with. If the other people that they have come in contact with, and do a first tier contact tracing. If the people that they come in contact with are also infected, then they should be and that way you will be able to monitor them. We now don't recommend the two negative swabs because once upon a time the WHO recommended two negative swabs 14 days after before you can be considered recovered. So now the WHO the WHO keeps shifting back and forth as well
Sure.
regarding this. Yes, but it's understandable because it's a new disease. So I get the fact that they really don't have a lot of information also on their hands. So now we know for a fact that if you um, if you still test positive after 14 days of illness and you're already asymptomatic for the past 10 to 14 days, it probably would just mean that there are skeletal remnants of the virus because the
Yeah,
RT-PCR.
but non-infectious viral fragments.
Yes, we don't know whether they're actually, once you get swabbed and you're positive, that it does not necessarily mean that the virus is active, and it can mean they're skeletal remnants.
But
So we
if
don't use
people are
that
still
anymore.
symptomatic, do you think? Sorry, if people are still symptomatic, do you think the infection persists for longer?
Sorry,
If people are still symptomatic,
yes.
does that mean the infection is persisting for longer? They're still infectious for longer?
Well, for after 14 days, if patients are still asymptomatic, you must think of a secondary infection. Because once you
Right.
come with a viral infection, this is self-limited. Whether you like it or not, patients will get better. So once they've come down, after 14 days and you're still symptomatic, you still have pulmonary problems, you're still intubated, you probably have a secondary infection already because of your intubation, staying in the hospital for quite some time. But in the majority, in those that have just mild, moderate diseases, they get better in 3 to 4 days.
Yes. So, as a general principle, if someone has a respiratory viral infection, how probable is it that they're going to get a secondary bacterial infection?
It depends on their immune system. For the patients that I've had, the pediatric patients that I have had, they recover very quickly. So I've had among my pediatric COVID patients, they've recovered very well. Even the one that had a very bad infection, she had actually urosepsis at the same time, but treated her with a broad spectrum antibiotic for the urosepsis, and she did better. They
So,
recovered.
infection of the kidneys and the bladder and the urinary tract.
Yeah.
Yeah. So this is interesting because if we look at pandemics in the past, such as the 1918 pandemic, 1919 pandemic, probably a lot of people who died in that actually died of secondary bacterial infection.
Yes.
Not necessarily a majority, but a lot. So as we have antibiotics now, and generally speaking, they're available. I mean, I'm hopeful that that's going to greatly reduce the case fatality rate. Would you share that optimism?
Yes, yes, I would. I would. And we have better healthcare today compared to the 1918s and to the 1920s. I mean, compared to 100 years ago, we have better healthcare. We have more. We have what's the right term that I should use? We have a better system at our disposal.
Yes. Yes.
Okay, we have more leverage now. We know what to do. We have better tools and we have better equipments, and these improve actually survival.
Yeah.
It also prolongs their stay in the hospitals, but the outcomes are much better.
Yeah. So we can expect hopefully 80% to have a very mild or asymptomatic illness. It's just this small amount, maybe 15% that get quite sick, and 5% or so that get critical. Is that roughly what you think you're seeing in the Philippines, that sort of ratios?
The data that we have in the Philippines is that 99.6% are mild. And
99.6.
yeah,
Wow. Yeah.
yeah.
Great news. Yeah. Right. Okay.
99.6% are mild or asymptomatic, and we only have 0.4% now that are critical or severe. So the numbers are relatively low. Even if you look at the data that we have, whether you're looking at the WHO's data, or you're looking at Johns Hopkins, or whether you're looking at Worldometers or the New York Times, whichever data that you're looking at when it comes to the Philippines, you will see our mortality 5, 8, 10. 5, 2, 10.
So so 0. About 0.5% of cases are critical, as opposed to 3, 4, 5% in the UK, for example. Are you getting a lower percentage of critical cases in the Philippines than other countries?
I think so. But
Interesting.
compared to our neighboring Southeast Asian nations, we're doing better than Indonesia, but we're not doing better than Thailand. We're not doing better than Malaysia. We're not doing better than some of our Southeast Asian neighboring countries.
Do you think there's a potential viral phylogenetic explanation for that?
No, I don't think so.
No, I don't either.
I don't think
It's the
so. I
same
just
virus pretty well, isn't it?
Yes, yes. I just
Like a
think
different
that the other
strain.
countries are more aggressive when it comes to treating the virus. But if you look at the data of Singapore, just look at the data of Singapore, they have more cases than we do. They're actually, in the beginning, Singapore had very few cases. And again, we go back to the WHO. The WHO was lauding them for their efforts. And then later on, they had a very huge outbreak.
It did,
And that
yeah.
very huge outbreak was coming from actually communities wherein their construction workers or these people who were building facilities were all housed together in a dormitory.
It's a
And that's
bit like the
outbreak.
meat processing workers in Germany and the States.
Yes, yes. So again, it is the congestion. I mean, it still goes back to the same point. If you do some epidemiology dynamics and some, you can always see that it's the congested areas, the crowded places wherein the transmission is actually the cause for these patients developing an infection.
Yes.
But you'll also see that the mortality rate among these patients are very low because they're a working population and they're younger.
Yes.
It's when they transmit the infection to the elderly or to those that are susceptible that we get higher rates of mortality. For example, the one in Seattle. I mean, you know the case in the
Yes,
United
I
States.
remember that. Yeah. Yeah.
Yeah, right. That they had multiple deaths in nursing
Yeah, the
homes.
Kings County, Seattle, yeah, in Washington State.
Correct.
Yeah, yeah. So I'm actually remarkably encouraged. Only about 0.5% you think are getting critical illness here. So the case fatality rate is going to be about 0.1 or something like that.
No, our case fatality rate was very high in the beginning because we were not, well, at the beginning of the pandemic, we were not looking for a lot of patients. We were not testing enough. And you know that to calculate the case fatality rate, that's the number of deaths divided by the number of people that
Yeah,
actually are
yeah.
ill. So the more we identify, the more positives we get, the better. So that means that our case fatality rate today, when we started this, was somewhere at 14%. We are now at 3 point something, 3.8%, which is
What would
good.
you estimate the actual infection fatality rate to be, though? I know you don't
At
have the data to answer that, but what's your guess?
the Philippines or the world?
No, the Philippines.
Philippines, maybe about 3%.
Right. Okay. So the potential in some poorer areas of the world for mass fatalities is still present then.
Yes, yes. But you know, what's really peculiar for me is the fact that I think that perhaps there is some form of herd immunity in the lower socioeconomic class. They're able to survive many of the more virulent infectious diseases that we've had in the past. And if you look at the data of um, poorer countries, the mortality rate does not seem to be as high as those that are more economically privileged.
And is that explained purely by the demographic, or is there great other reasons for that?
Well, I think there are multiple reasons. And one of the reasons, like I said, one of the reasons that we probably have less deaths is because we have a very young population.
Yeah, so you've got less chronic heart disease, you've got less chronic obstructive pulmonary disease because these diseases are associated with older people.
Right? We have them, but they're not that. While we have them, they're not that plenty. The second thing about this is that while we have them, um, the enhanced community quarantine that was put in place in March has uh, has has not allowed the disease to actually affect the elderly and those that have comorbids. You
Yeah.
know, the Filipinos are. There is one thing about the Filipino. No? If you tell them that you're going to die, they're not willing to go out. They're not going to risk their lives, especially those that are more affluent. On the other hand, in the poorer communities, they're willing to do anything to survive.
Yes, because what they eat that day depends on what they earn that day, doesn't it? Yeah.
Correct. Correct.
Yeah. So herd immunity may well be developing in the Philippines, and I suppose we'll only know when we get extensive antibody testing.
Yes, yes. I think that is a research um, that is a research topic that somebody who is interested in would probably want to do, particularly among the urban poor communities. But
There's
I
so many
think
PhD opportunities at the moment, isn't there?
yes,
Let's hope people take these up. Yeah. So, is there much diabetes in the Philippines? Because that's a significant comorbidity, isn't it?
yes, there is a lot of diabetes as well. Most of the endocrine problems, you have diabetes, you have hyperthyroidism. Of course, you include all of the other comorbids like hypertension. That's we see a lot of that also in the country, particularly for those that are above 40 years old.
Hmm.
But majority of them are actually type 2 diabetes and rather than insulin dependent or type 1
And of
diabetes.
course, this is remarkably common all over Asia, isn't it? Type 2 diabetes. It's
Yeah.
another pandemic, isn't it? It's
Yes. Yes.
yeah, which is of course would be a fascinating topic for a different different video. Now, what's your view on the vitamin D status in the Philippines?
Oh, we get a lot of that in the sun.
And do people get whole body exposure to the sun, or do people? There's a lot of sun in India, but culturally people keep out of the sun. So is the Philippines different to that?
We're very different. I mean, we love it. It's like second nature to us. We need to get out. We have a lot of sun. We are, like I said, we're 7,641 islands, which makes the beach something that is right annexed to many of our front doors.
You are indeed fortunate in that respect. Right, so that's interesting. So there's not widespread vitamin D deficiency in the States, for example.
Yes.
42% of the entire population of the United States is vitamin D deficient.
Wow.
And when you look at the Black American, African American population, that goes up to about 70 or 80%. So in the Philippines, it sounds like vitamin D levels are going to be basically adequate in the vast majority of the population. Do you think that could be part of the reason you're seeing small amounts of disease in the Philippines?
There's been no extensive study correlating the two, but if there is a correlation between the two, between vitamin D and the outcome of patients who have COVID-19, then good for us, hooray.
Well, indeed, indeed. But you don't think it's a ludicrous hypothesis? You can see that vitamin D is an immunologically required molecule. Does the science kind of make sense in your head that that's a possible
Yeah,
explanation?
it makes sense actually. It does make sense, but we probably will have to look around also at other countries within this. But in general, if you look at the Southeast Asian nations where we have a lot of sun, okay, and you see how the people in the Southeast. I'm not talking about the whole of Asia, because the whole of Asia would probably include China, Japan,
Sure.
Korea.
Yeah.
Among our northern Asian neighbors, um, they really had a very bad winter. They had a lot of cases of coronavirus, of COVID-19, due to the fact that when this started sometime in December, January, February, and March, it was winter for them. We never have winter here. So if you look at the cases in the Southeast Asian nation, you probably are right, because we have very low cases actually within Southeast Asia alone.
Interesting. Because, I mean, I'm assuming that the nutritional status of the urban poor, particularly, is not necessarily that good.
Yep, you're right.
Yeah. So that's interesting. I don't want to take up all your day because, but it's so interesting. Can I ask you? I've got another clinical question. For for
Sure.
for years, when someone has an infectious disease, obviously the white cells are going to recognize that. They're going to release the cytokines. The cytokines are going to affect the hypothalamus, and the hypothalamus is going to induce the fever. My thinking there is that the fever is a physiological response to the infection. It's adaptive, and that the fever will reduce the efficiency of viral replication and improve the efficiency of the immune system. Do you think what I've just said there is clinically valid and clinically true?
To some degree, yes. And I've always told my patients that fever will always be your friend.
And yet in the UK and the United States, whenever someone has a fever, they tend to take fever reducing antipyretic drugs to bring the fever down. If someone has COVID-19 disease or another viral disease, do you think it's better that they leave their fever at the higher physiological level rather than they artificially bring it down using acetaminophen or paracetamol or ibuprofen?
I never recommend a non-steroidal anti-inflammatory drug, an NSAID. That to me, it does not. It brings down the fever much faster and much better than paracetamol or acetaminophen. But it can also, because it from the nature of the drug, it's an anti-inflammatory. The inflammatory cells in your body actually help in fighting off part of whatever infection you have. So that's not part of my armamentarium, and I really don't recommend it. Well, the other doctors do, but from an infectious disease point, it does not make sense. And
The inflammation is very much part of the body's response, isn't it? Very much part of
yes,
the
yes,
immunological
yes,
response.
yes, yes. It's part of our immunological response, and that's the only way we can create antibodies sufficiently. And you're right, when you go through all of the other mechanisms of how our body is able to recognize an infection, create antibodies, and create other molecular structures within our body in order to fight off an infection. And when moms ask me regarding fever, I always tell them you just wait for 2 3 days, just monitor it. If it's higher than 38.5 and he feels cranky, you can give him a dose of paracetamol, but you don't have to give it round the clock. Because sometimes if you see the kids, well, because I'm a pediatrician,
Mm.
so if you see the kids and they have a temp of 38, 39, some of them are still playing. I tell the moms, you take them to me when they're not eating, they're not playing, and they're just sleeping. But otherwise, look at them.
So
They're
it's
still
treat the
active.
child, not the fever.
Yes.
Yeah, it's amazing that you
It's
can
not
see
disturbing the
people
child.
temperature 39 and they're just out playing like normal. It's amazing sometimes.
Exactly. Exactly. I always ask the moms that. Is the fever bothersome to you or to the child?
Yes.
And she goes, well, that's their answer. I said, see, it's not bothering the kid. You leave it, count 2 3 days, it might go away. Unless, of course, the child has other symptoms. Like, for example, the child is vomiting or the child has diarrhea, has abdominal pain, or has seizures. Then that's a different story
But then you're
altogether.
looking for the etiological organism of that, aren't you? You're looking
Yeah,
for the
yeah.
underlying cause of that.
But the
Now, what?
patients just come with,
Sorry.
yeah.
Well, what
No,
people worry about a lot in children is febrile convulsions. What
correct.
age group of children can get febrile convulsions, and how common are they?
Well, the general rule is 6 months to 6 years old.
Yeah,
Okay, so you just remember six.
6 to 6.
Okay.
Yeah.
Yes, 6 months to 6 years old. That's the most common age group. It peaks around 2 years old, 1 to 2 years old, and there is usually a history of somebody in the family who has had febrile convulsions as well when they were kids. And it does not occur very frequently. As a matter of fact, some of the patients that have had it may never have it later on. So
And if a child does have a single febrile convulsion, that's not going to kill the child or anything. That's a fully recoverable situation.
yes, and we don't start patients on anticonvulsants when they have had
No.
a febrile seizure anymore. Once upon a time, again, in the olden days, people every time they see patients who have had febrile convulsions, they are started on phenobarbital or phenytoin routinely. But we've seen enough evidence that starting patients on anticonvulsants is not the right way to go.
Yeah. So 7-year-olds are not going to have febrile convulsions. They can almost be
Well,
treated like adults in that respect.
um, if you have a patient who is 7 years old and has seizures, it's still possible because febrile convulsions can occur up to an extended age, even up to 8 or 9.
Okay.
However, as a general rule, we look at a normal distribution curve. And if you look at the normal distribution curve, they are at that end of the distribution curve where they probably should not be having seizures anymore when they have fever, especially if it is the first time that they are presenting with fever and seizures. So
Right.
you need to, because that might present as a red herring, and you must look for a different etiologic cause for why the patient had seizures during the fever. You might miss out a bacterial meningitis in your patient.
Indeed, indeed. And the other thing that always concerned me about children, because I get questions on this all the time, is very young children can't control their body temperature in the same way that older children can. And there's a risk that the temperature can go up very highly to dangerous levels. Um, and of course, if the temperature goes too high, that can result in brain damage potentially. If the temperature reaches, I don't know, 42 degrees centigrade, maybe. What temperature would brain damage be a risk in children, do you think, young children?
I've had kids that have had even up to 40, 41, and I've not had a brain damaged child with that. If you're just looking at fever in itself, you have to remember younger children actually, the reason why younger children have more episodes of fever and higher fever is because this is an age group wherein playing for them, when they don't feel that sick, the first thing that the first instinct they have is to just go out and play.
Yeah.
Even if they have temp, they're going to run. You drag them to school, they're going to kiss their classmates, they're going to run around, which exacerbates the fever of the patient because of the insensible water loss from the perspiration. See, if they perspire, they have more insensible water losses, and that brings the temperature up. They will not hydrate themselves. On the other hand, older children are able to recognize that they have fever. And because they're able to recognize that they have fever, the tendency is they will rest,
Yes.
unlike the young kids.
I've always taught that, I don't know how accurate it is, I'm no specialist, but children up to the age of 2 can't really effectively control their body temperature. and they're more at risk of increasing temperatures rather than children over the age of 2. Is that a fair kind of cutoff, or is it more diffuse than that?
Well, I think it's more diffuse than that.
So it's kind of children would learn to control their body temperature between, say, 18 months of age and 3 years of age, that sort of.
I think the kids that are more than 4 or 5 years old should be able to control their body temperatures more than the younger ones.
Right. Okay. That's useful. Yeah. Because it's just. I mean, last year I was working on an A&E department, and when children come in who are unwell, giving them ibuprofen and paracetamol is just so routine and universal. And I always question this, but this entrenched practice is so hard to get over. The symptomatic treatment as opposed to a causal treatment.
Well, I guess I think the reason why some patients receive symptomatic treatment is for the sake of the parents or whoever is the caregiver, because to them, you know how patients are when they go home without a script or without a prescription. They feel cheated, or
Yes.
they're
Yeah.
not being paid enough for that.
They need some magic medicine. Absolutely. Yeah. Yeah. Yeah.
Yes, even if you gave them something that is placebo, many of them will go home and say, "Well, right, now
It's
you
an
have to take
interesting
this."
question. Yeah.
The
Yeah.
doctor said.
Yeah.
Yeah,
I just got one more question, if you don't mind. Is that okay?
yeah, that's fine.
Yeah, because I think this is. I'm working with colleagues in India at the moment, where I'm quite concerned about widespread potential fatalities in India. And we know that a lot of people that deteriorate with COVID-19 are going to get sicker in the second week, not so much as the result of the virus, but as a result of the inflammatory reaction to the virus. That can potentially result in the severe acute respiratory syndrome, for example, which is primarily inflammatory. And we know that that's what we now know, that dexamethasone can be effective in treating some of these inflammatory changes in the second week. What I'm unclear about is how are we going to differentiate between a patient that's deteriorating because of an immunological inflammatory reaction to COVID-19 as opposed to a patient that is basically recovered from the COVID-19 but is developing bacterial secondary infection?
Difficult question. It's very difficult when you're. It's a difficult question because it's a personal call of the attending physician when he sees the patient. So it's individualized. Like, for example, if I see that kind of situation and I know that the patient should have been recovering already, but suddenly deteriorates, I probably would have some laboratories redone,
Yes,
and
yes.
I probably would have CT scan or more chest X-rays done in the patient.
Yeah, you would
And
investigate them, absolutely. Yeah.
yeah,
Yeah,
yes,
yeah.
I will have to reinvestigate and see if the WBC is all the way up, the CRPs are up, the
So
ESRs are.
if the neutrophils are up, it might be a bacterial infection, for example.
Yes, sometimes you might, because most of the patients with viral infections will have normal white blood cells, and they will have some form of leukopenia for in general.
Yeah, so a low
Even
amount of white blood cells.
yes. So if there is an increased amount of white blood cells in these patients, then you might want to think otherwise, that these patients are
Yeah,
probably
yeah.
getting a secondary bacterial infection.
So my hunch would be, if I wasn't sure, I would probably cover it with antibiotics anyway. Would that be?
Yes. In my cases that I get, especially the complicated ones,
Yeah,
this is pre-COVID, not post-COVID.
yeah,
Okay? Pre-COVID, which means that this is before the COVID epidemics.
yeah,
Um, when I get cases that is a toss-up between acute respiratory distress syndrome. So these are adult respiratory, they go into ARDS, The lungs are completely wiped out, and we
Yep.
don't know whether the patient has a bacterial infection that's causing it
Yeah.
or a viral infection started it, and that's the reason why they're intubated. I actually put the patients on both the antibiotic and dexamethasone
On both.
because yes, on
Yep.
both.
Yep.
Because even if that means that I would have had the patient covered for both a bacterial infection. After working up the patient, I have to work up the patient first, and I'll
Sure.
start the treatment almost immediately. And the reason for that is if this is ARDS, you have to remember even bacterial pneumonia can trigger ARDS, and ARDS patients will respond remarkably to any corticosteroid, whether you're giving hydrocortisone, whether you're giving dexamethasone, or whether you're giving any other parenteral steroid to the patients. And I have a lot of patients that remarkably do better after that. That it's also possible that they've had a secondary bacterial infection that triggered the ARDS of these patients, but you can't tell. You
Right.
can't
But
tell.
you cover that with antibiotics anyway.
Yes, yes, and it's a personal call that you
Yeah.
will have to make
No,
to
I
judge
just think
yourself.
antibiotic availability is going to be a big factor in reducing case fatality rates in this pandemic.
Yeah, but it's widely available. A lot of
Yeah.
the antibiotics are actually widely available.
Yeah. 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 Dr. Coe, that was brilliant. I've kept you talking for about an hour now. So, and I know a lot of people around the world will watch this all the way through. I think there's some really useful things in there and well, life-saving things. So we're really grateful for your time, and I'm sure you get lots of positive feedback on this from around the world.
Thank you.
Yeah, yeah. So do you see a vaccine coming next year? Just as a quick one to the end.
Um, I'm hopeful, but I don't think next year will be the year that we will see the vaccine.
Oh,
It
really?
will take quite some time for vaccines to get developed. You have to remember that while it while we are I know there are three vaccines currently that are already in phase two. There are a lot of vaccines that are actually in phase two, but they are of different platforms, like the one of Moderna, the one from Oxford, and the one from China, are actually trying to go into a phase three clinical trial already. It's kind of complicated in the sense that if you go through the history of vaccinology, you will need to make sure that these patients actually have an immunologic response to the vaccines. Like, I mean, if the vaccine is effective and safe, do you need just one dose of the vaccine, or will you need multiple doses eventually? Because if I start the patients now and I put them on a clinical trial and I monitor them and find out that after 30 days the antibodies go down, they might need a second dose in order to put their antibodies up again. So I might need two or three doses, which will now prolong the clinical trial stage in order to find out at what level will these patients be protected, and how many of these patients that get into the clinical trial will actually reach protective levels.
Yes.
So that part of the clinical trial, unless we know, I tell my patients and tell everybody to let's just live in a world without the vaccine for a while. I mean, at the rate we're going, we're almost 10 million by the end of the month of June, which means that that would have covered quite a number of people in this pandemic.
Right.
Let's try to live without the vaccine for a while.
Then if the
We
vaccine
need,
comes, that will be a wonderful bonus.
yes, yes,
But
that
we
would
can't
be
we can't count on it.
your terms, a wonderful bonus. Because you have to remember, even though you're able to come up with it, then you have to make sure that there are enough doses for everybody. And the different platforms that are being used, whether they are live attenuated, whether they're genetically engineered vaccines, and so on and so forth, will matter because for some of them, like for vaccine A, you might get an efficacy of, let's say, 80%, for vaccine B, 65%, and vaccine C, 90%. But either the problem you will get for the three vaccines, or let's take for granted that they're all 75% in efficacy in protection, you might not, because they have different platforms, they're coming from different platforms, they're not interchangeable, especially if you need multiple doses, which means if I get vaccine A, I must continue and finish vaccine A, and so on and so forth down the line. So it's kind of complicated at this point. And then you have to look at the manufacturing side. I mean, we have 8 billion people in this planet. If everybody wants a dose of the vaccine, there has been no vaccine created for 1 billion doses in the world. None. I've never seen one. And you'll need how many syringes, glass syringes, manufacturing plants, needles, and so on and so forth. So while we were able to develop one, I don't know if there is sufficient manufacturing capacity for all of the vaccines as well.
Yeah.
So that's a reservation.
So yeah, that's okay. So we're not gonna wait for that. We're gonna carry on with what we're doing now and hope for the best on the vaccine. Yeah, that's good advice. Yeah.
Actually, what I'm hoping for is that there is a cure. I think the way to go would probably be a treatment rather than the vaccine.
Antiviral therapeutics.
Yes, yes. And I think there should be more resources poured out at looking for a cure for the disease, for the infection. Because some of the patients, because the way I'm seeing it now, is that the majority of the patients are actually presenting as mild, they're recovering well. 9 million cases, 400,000 deaths. I mean, they're doing remarkably well in spite of the fact that we don't have vaccines. So they're recovering practically on their own in the majority.
Yes.
What do we need? We need a cure.
Yes.
More than the vaccine.
That would be excellent, wouldn't it?
Right.
That would be great. Yeah. Dr. Coe, thank you very much. You've given us well over an hour of your remarkably busy schedule, and we really appreciate it. So
you're welcome.
Thank you so much for that. Thank you.
Okay. Have a great day there.
Yeah, you too. I'll stop the recording now. Thank you, Dr. Coe. Really appreciate it.
Bye-bye.
No, bye-bye.